tiếp theo chương trình thì chúng ta sẽ nghe một cái báo cáo từ một cái đồng nghiệp ở Thái Lan nghiên cứu giải phẫu bệnh trong các điều kiện hạn chế nguồn lực. I would like to introduce and invite Professor Shanop Shuangshoti from Chulalongkorn, Thailand. With his talk is about the pathology and research in resource-limited setting. Please, Professor.
So good morning, and I'm very happy to be here again. So today I'd like to share with you about what I'm doing research in Thailand. And I consider Thailand is a limited resources country as well. And it's not my research. I'm going to share some of my mentors' research as well. So first of all, I think we need to distinguish between research and publications, because to me I think some people today they're just doing publications, but I don't think they are doing research. So today I try to focus on research, and this is a pyramid of the art and the science. Can you see the differences? The same, right? If you look at the black pictures, silhouette, the shadow. But I think it's very different, because in the art side, if you want to get famous, you can upload your clip, sing a song, and you can get famous overnight, right? You put the towel here, and you can get famous. But for the science, it's like you have a brick, and you have to on top the brick with the new information. Otherwise, you cannot get the research. So this is a difference between art and science. So if you want to get famous overnight, you have to quit the job from science to become the artist, and you have a chance. Yeah, K-pop, something like that. Okay, so example, if you discover TP53 mutation, this is a huge discovery. Even though we cannot do anything to the TP53 now, but it was a huge discovery. And then you can go down and can see some less impact and less impact if you keep asking some question like, what about the TP53 mutation in Thai people? It would be the same. Some exception we know about EGFR, right? EGFR is different across the countries, but most of the time, if you continuously ask the same question, you're not going to get the new finding. And this is very typical research question for the pathology residents, right? So you have to come up with a new way of asking the questions. So you can get who said this statement is a scientist, not an artist, and that is all truth. Easy to understand once they are discovered, but the point how we discovered them, and it was Galileo. Okay, so when we have a healthy and we have a disease, so this is a job of the pathologist. So we diagnose the tissue, we grade, we stage, and this is our job. For the oncologist, you have to treat the patient. And this one is very difficult. Pathogenesis is very difficult. How many diseases that we don't know the pathogenesis? If you read the login, how many times they say the pathogenesis is uncertain, is unknown. So if you want to do research in these areas, it's quite difficult. And if you can, if we know the pathogenesis, then there is a chance to prevent or we can treat it. Okay, so limitation, I think the same here, right? If you can think of anything else, let me know. But the first thing is very important. If you don't want to do the research, then nothing happens. It's unlike in our cases, even you don't want to do it, you have to do it because oncologist will ask for the result. Okay, so, but for research, if you don't want to do it, it's fine. Okay, so in pathology, what we can do, I think it's descriptive case report, case series, clinical pathological study. You can do a diagnostic test, but the problem with the diagnostic test is that all of the tests that are available commercially, they only publish a lot of the research. Antibody, when we got the antibody, many publications already published, right? So we don't have the new test that is really new in our lab. Most of the tests, you can do basic research. So this is my sample size calculation, not for citation. But if you're doing small n, high impact, it's just like a case report. I love case report because you can discover something, some new finding. So I do it, and many times you can get published. The good case report. This is small n, low impact. It's good for practice. Maybe you want to do it. This is a large n, high impact. We don't have enough time to do it. We don't have manpower to do it. So it's unlikely to happen in Thailand. If you have a large n, high impact, maybe. But if you have to do a large n series but low impact, don't do it. Okay? So focus on the small n and high impact. So when you want to do research, you have to have the problem, not the problem with people, problem with the lab, you have to, you need to have, identify problems by observation, and you have to question. And when people face with the problem, some people just ignore and disconnect because they say, oh, people around the world face the same problem, and then they don't know how to solve it. Then we cannot. But if you have the intention to solve it, then you do a literature review, and you have to think differently, and you do a research, and then publish. So publication is not the goal of research, but it's just the way to tell people how you solve the problem. So I think there are 4 factors influencing the research outcome. The first is the idea, technique, specimen, and speed. So just give an example of nasopharyngeal cancer research. It's not mine, but it's my mentor research. So people know for a long time that EBV is associated with NPC. How come he discovered that he could detect EBV in the plasma of the nasopharyngeal cancer patients? And this was my mentor, Professor Apiwan. Many people thought that this was discovered by Hong Kong researchers, but actually it's not true. It was discovered by the Thai research team. So how come he came up with this idea? Because he read this paper. So it's a paper back in 1996 in which the microsatellite pattern of the cancer patients, head and neck cancer, was discovered in the plasma. So Professor Apiwat read this paper and he thought, why won't he try it with EBV in the plasma of NPC patients? And that's he discovered it. So you can see that the idea doesn't come from the air, but you need to have the fund of knowledge, and then sometimes it just happens. So when he read this paper, he just got the idea that why won't he try EBV in the plasma of the patient with the nasopharyngeal cancer, and that's how he discovered the new finding. And remember, at that time, EBV could be detected by PCR in any lab in the world. So he didn't have the advantage of the technology, but he has a different thinking idea. So EBV, you can see that he didn't have new technology, but he has the idea. And he had the specimen. And you know, he had the speed as well, because he published just a few months before the Hong Kong researcher team seeing the same thing. Okay, so that's, I became to know him when I was the resident. When I was resident, I was trained by my dad. He was a neuropathologist. And I looked at the cases with my dad, and you can see that to diagnose astrocytoma, you need to see some certain morphology to make the diagnosis of a high-grade tumor. Okay, so we still use this. So when I look at the slide with my dad, I was, you know, sometimes the sample is small, and you couldn't see the high-grade features. So I started review the literature at that time, many years ago. So I found that this is in the literature at that time. So they have some genetic information of the astrocytoma at the different histologic layers. So I didn't follow this, because if I ask how many Thai astrocytoma has all kinds of these genetics, so I didn't ask that question. And what I did was, so I met him, and I knew that he has the technology in his lab. He used the microsatellite to study LOH in the nasopharyngeal cancer. So what I did was, I looked at the big tumors of astrocytoma, and you can see that in the same tumor, you can have a different gradings in this tumor. So I macro dissected a different grade, the same tumor, and analyzed it with the microsatellite. So we were able to identify some genetic heterogeneities within the same tumors. So, and this was published. And you can see that it's in the 2000, and you can imagine at that time, people didn't talk much about the heterogeneities. So that's how we come up with the new finding. So for the astrocytoma, you can see that, again, idea is very important. Technologies, at that time, people can do microsatellite, and all people has a glioblastoma specimen. So I learned what I learned when I worked with Professor Apiwat. I know that when you are MD and you work with a PhD, you can have a good research. Some of you are MD and PhD, you can confuse yourself. So you can talk to other people. You don't have to have the MD and PhD, but we should work together. Okay, so yeah, this is a famous pathologist, one Rosine. He says that you have to combine many modalities to come up with a new idea and a new finding. Okay, so what about idea and techniques? Okay. I worked with Professor Apiwat several years, and he switched from NPC to epigenetics. And one day, he showed me that he had a paper. He found that epithelial marker, and he called it CHIP1 promoter 2, and he told me that this is a specific methylation marker for epithelial cell. And he has the technique to measure this. And he asked me what you want to do with this marker. Okay, so as a neuropathologist, I read the Pathology as well, and you can see this is a metastatic adenocarcinoma in the CSF. And the CSF is very good because you don't have the mesothelial cell. I think mesothelial cell is some kind of epithelial cell, and they may have a CHIP1 methylation. So I think the CSF is a good example that good specimen to run the CHIP1 promoter 2. And indeed, we found that in patients with leptomeningeal metastasis has more CHIP1 promoter 2 methylation. Okay, so this is an example that when you collaborate with people in the PhD, they can have some new tests that you can do in your sample. What about specimen? What is the when you have an advantage of the specimen. So I met another guy. He is a rabies expert. Professor Thirawat. And this is his hobby. And yeah, he showed me one of his guitar. He's a rocker. Okay, so rabies infectious diseases has been with us for a long time. And the rabies has two forms. One is a furious and one is a dumb. I think we all familiar with the furious one, the mad one. And this is a percentage of the furious form and dumb in human, dog, and cat. Okay, so this is in the human, so this is the furious one, and this is the dumb. And you can see that the conscious in the dumb rabies remains, the patient still conscious, still intact. They don't go mad. Okay, and in the dog as well. In the dog, you have the furious, rabies, and the dumb. Okay. So I didn't know much about rabies. The same with you. I just know the nuclear bodies and bullet shape, the EM. The problem is, what is the mechanism underlying the two forms of the rabies? Why one patient has a furious while another has a paralytic? So there's simple but difficult to answer. One is the host and the wife. And even more interesting because sometimes the one animal can switch from dumb to furious and furious to dumb. So very fascinating to me. Okay, and this is a Dr. Thirawat paper, and he's I think he gave the patients immunoglobulin, and the patient with furious become paralytic. So it's switching the variants. And he told me, this is US, tell me, he found one dog bit two person, and one got the furious and another got the paralytic. Okay, so when I joined the team, previous study by his team, he found no difference in the viral distribution, inflammation is mild, and same MRI pattern, almost the same viral genome. So he everybody pointed to the host. And I joined the team and I looked at this. He studied electrophysiology in the patient with the furious and paralytic rabies. And they found demyelination in the paralytic rabies, and they found anterior horn cell dysfunction in the furious one. And he asked me to confirm whether I could identify demyelination in the autopsy sample. But autopsy sample, it was fixed in formalin, so I couldn't tell whether there was a demyelination or not. But I found just a simple changes, and that was the central chromatolysis at the anterior horn cell here. And this matched to the anterior horn cell dysfunction. So in patient with the furious has the anterior horn cell dysfunction, and we have a central chromatolysis. So this was interesting because it's the first time that we could see differences. So I don't know how come he got this idea. He believed that we couldn't see the differences because we examined everything at autopsy, post-mortem. Maybe if we could observe changes at the early stage, maybe we could see differences more. So he put the dog, the mad dog, into the MRI. So this is a dog. You can see the idea. And this is the MRI of the dog with the rabies. Of course, we sedated the dog. The dog was sedated before we did the MRI. And after the MRI, we sacrificed the dog to see the brain. And this is MRI. And you can see that in the paralytic rabies, you have a flare signal in the brainstem. So different now. In the paralytic, we have a less virus and more cytokine, which is more inflamed. In the furious one, we have more virus and less cytokine. And this is the imaging. So at the earth stage, there are differences. And that is, you have the damage in the brainstem, inflammation. And so inflammation at the brainstem in paralytic rabies, just blocking the virus to go up into the brain. In the brain, more virus in the furious one. And I examined the postmortem. We did, and we mentioned in the brainstem. So this is new finding. So we have in the paralytic dog have inflammation in the brainstem that block the virus to go to the brain. Okay. So that is delay the disease course. Why brainstem is inflamed? I don't know because we couldn't ask the dog. But I think when the dog bites, usually it's bite at the face, and the face will have the cranial nerve. And so this is my speculation that the virus go to the face, cranial nerve, and then go to the brainstem. So my speculation, we couldn't ask the dog. The dog couldn't tell. Okay, so we published this in the Lancet Neurology. So I am a cancer man. So when you look at the cancer, you have the primary tumor, you have the basement membrane, you have the metastatic tumor. So in the rabies, you have a spinal cord, you have the brainstem inflammation. So I just hypothesized whether there may be many viruses at the brainstem, at the spinal cord, and some might have something special to go up into the brain that they can pass the brainstem inflammation. So I hypothesized whether virus in the brain and spinal cord may not be the same. Okay, so you want to know the answer? Yeah. So it is a long story, but the first master student who did this, she didn't finish it. She got the PhD position in the UK, so she went to the UK. She didn't finish my project. She already died of liver cancer. The second student, she very good. She wants to make my hypothesis correct. So she faked all the data. She gave me the wrong data to say that my hypothesis is correct. So the second student was fired. And the third one, okay, we have the answer now. So virus is the same. So it's back that the host is the main factor that contributes to the different symptoms. So if this is correct, if you happen to have a paralytic dog, if you give the immunosuppressive drug, maybe you can switch from paralytic to furious. Okay. Not published yet. Okay. Last. My recent papers. So we studied meningioma. So everyone has a meningioma in the lab. And what we did was, I was trying to find the factor. Some meningioma has a brain invasion, but I want to find what is the mechanism of the brain invasion in meningioma. So what we did was we dissect the invasive and non-invasive part, and then we ran the nanostring, and we pick up the candidate genes that involved with the brain invasion. So we compare the invasive part to the main tumor of the same tumor. So we come up with all the candidate genes here. And we validated it with the immunohistochemistry. So we discovered that DTX1 and RAS, RAS-GRF1 are the genes that are associated with the meningeal migration. So we just got this published. So this is again is an idea because you all have meningioma. Other lab has nanostring, other lab has the immunohistochemistry. So this is how we came up with the new finding. Okay, I think I hope that I still in time, have 40 minutes, and I think I have gone over this. And if you want to do research, at least there are 4 factors. So idea is very important. A technique, specimen. If you have a specimen that people don't have, you can be lazy. You don't have to have the speed. But if you have a specimen that other people also have, you have to do it quick. Okay. So having said that, I think you have a duration, acceleration. It's not enough to complete the job. You have the discipline to do it. So with that, I think we can overcome all the limitations. And this is all my people that helped me and inspired me to do the research. Thank you very much for your attention.
Thank you very much, Professor Shuangshoti, with very interesting presentation. I think our Vietnamese pathologists, especially the young pathologists, can learn a lot from you, from your experience. Thank you very much again. And we will back to discuss more at the end of this section. Now, okay, you can stand here to answer some questions. Yeah. Tôi định là để đến cuối, tại vì trong chương trình là đến cuối của cái phiên này chúng ta mới thảo luận, nhưng mà có thể là sau đây thì chúng ta sẽ thảo luận luôn. Theo ý kiến của giáo sư Sở Trung thì chúng ta sẽ trao đổi luôn với giáo sư Shuangshoti. Vì giáo sư bận, có thể sau đây thì sẽ phải rời hội thảo. Tôi vừa mới nói giáo sư là đây là một cái nghiên cứu, một cái báo cáo rất là thú vị. Có thể chúng ta sẽ học được rất nhiều từ cái kinh nghiệm của giáo sư Shuangshoti trong cái cách đặt vấn đề nghiên cứu, từ cái ý tưởng cho đến thuật, cho đến chọn lọc, cho đến thời gian để cho. Và tôi rất là tâm đắc với cái ý kiến của giáo sư vừa nói. Không phải các cái vấn đề khác quan trọng hơn. Thì xin mời các quý đồng nghiệp có ai có ý kiến trao đổi hoặc là đặt câu hỏi cho giáo sư Shuangshoti, xin mời. Okay, Professor Antonio. Okay.
So, using question, how about the sensitivity of your ideas? What success rate of your? How many ideas do you have to have before you get one hit?
I think, very difficult question to answer. But I think most of the time we don't have the good idea every day. I think you need to have the final knowledge first. It's like if you are a musician, if you want to improvise, you need to have the background of the theory, the mode, or something like that to improvise. So you need the data first. The good idea didn't come from the air. You need the data in your brain, and it's come when you don't think about it. Usually, if you think about it too much, it won't come. The good idea won't come up in the brain. But you need information, and you need to clear the brain. Like Isaac Newton, I think when he sat at the bottom of the apple tree, he didn't think of anything. So, good research question doesn't come every day. If you can think of research question every day, that is not good, mostly. Thank you.
Thank you. Any more questions, please? Okay. Em tự giới thiệu.
Em xin tự giới thiệu, em là bác sĩ bệnh viện viên khoa nhập ảnh. Thì cái comment là do
Okay. This is pathologist from Đà Nẵng Hospital.
So, em xin nói tiếng Việt trước. Khi mà em nghe thầy với lại Dr. Antonin có nói chuyện với nhau thì em không biết là em có hiểu nhầm một xíu không? Thầy nói là không có cần phải suy nghĩ về cái câu hỏi nghiên cứu ở trong đầu mình luôn luôn như vậy. Nhưng mà em nghĩ rằng cái câu hỏi nghiên cứu là nó luôn ở trong đầu mình khi mà mình thực hiện, khi mà mình làm việc, nó là xuất phát từ những cái việc mình thực hành hàng ngày. Nó cho mình cái câu hỏi vì sao cái môn bệnh học như thế này mà bệnh nhân nhìn nó rất là lành tính nhưng mà sau nó lại tái phát. Thì em luôn nghĩ là cái câu hỏi nghiên cứu là luôn ở trong đầu mình trong thực hành. So I have a comment that in our practical routine, I always have a question when I practice my job. So why it look like benign? It's so plain. So why? So about 3 or 2 years later, the patient will have a recurrent, like meningioma. I always have a question. When I'm always nervous about that. What? Why? So I really want to have more identify. You know, in my lab have no equipment to have molecular testings to confirm, to update to WHO classification. So just morphology is not enough for me. So I really want to have I really want to have another testing, so confirm my morphology. Yeah. So I think the question is on practice.
Yeah, thank you for sharing that. I think we have to separate research and the routine practice. Everything that's in the research, it will go into the practice. So research is a research, because even though we identify the tumor's invasion in the meningioma, it might not become in the routine practice. So we have to do what we can do the best right now with the resource that we have. Yeah.
Thank you very much. And get to receive the certificate and give the organizing committee. I would like to introduce Professor Shuangshoti on behalf of the organizing committee. We will give and certificate to Professor because after now he will go to the airport. Mang chứng chỉ với quà. Xin kính mời thầy Shuangshoti lên sân khấu trao chứng chỉ và quà cho giáo sư Shanop. Còn các báo cáo sau thì chúng ta sẽ trao vào cuối phiên này. Đây là kết thúc phiên này. Cảm ơn giáo sư Shanop. Thank you very much for presenting.